Hello, my name is Dr. Anthony Caiafa. I'm an Adjunct Associate Professor at the School of Veterinary and Biomedical Sciences at James Cook University in Townsville. This is a part of a 3-webinar series, the first webinar being Dental Radiographic Interpretation, What is Normal Anatomy? So if you can see on the radiograph on the left side, tooth 304, which is this one here, has a normal periodontal ligament space around it, especially at the apex. If you look at the tooth next to it, it has a crown fracture with the green arrowhead, and the yellow dotted circle shows that there is periapical lysis and periodontal ligament widening around the apex of that tooth. In a journal article by Dr. Frank Verstradi, he demonstrated that even when abnormal findings were not found on oral examination, around a third of dogs and nearly half of cats showed clinically significant pathology on intraoral radiographs. And even more so when abnormal findings were found on oral examination, over 50% of cats and over 50% of dogs showed further pathology which needed treatment. These are some of my tips when interpreting dental radiographs. Dental radiography is a special diagnostic test. Don't forget there are other diagnostic tests that you need to perform at the same time, and this includes periodontal probing. So we should not perform radiographic interpretation in isolation, and we must combine this with a thorough oral examination and the use of these other diagnostic tools. It's a good idea to take a full mouth series of radiographs. This helps you identify what is normal and therefore will help you identify what is abnormal. If in doubt, radiograph the same tooth but on the opposite side, and this will help you compare between the two teeth. There are special radiographic techniques such as a Tubeshift which avoids superimposition, and this allows us to visualize, say, the apex of the maxillary canine tooth when we take a mesiolateral view of that tooth, which pushes the apex over the nasal cavity, or when we're radiographing the distal root of the maxillary fourth premolar, often the maxillary first molar is superimposed over this distal root. And by doing a tube shift to the caudal, the distal root is actually pushed in a rostral or mesial direction to allow us to visualize the apex of this root. Radiographic positioning of the patient is essential to obtain diagnostic images. In my opinion, for predictable and reproducible imaging, we require the patient to be in sternal recumbency for maxillary views where the hard palate is parallel to the tabletop, or for mandibular views the patient is in dorsal recumbency with the mandible as parallel to the tabletop as possible. It is important that when we have taken our radiographs that we mount and view the radiographs in a certain way, and this is called labial mounting. With this, the maxillary crowns will point downwards, as you can see in the middle image. With 104, 204, the crowns of those teeth are pointing downwards, with the mandibular crowns pointing upwards, so 404, 304. If we're taking a lateral view of quadrant 1 or 4, the animal's nose is to the right when viewing the radiograph, as you can see on the left-hand side images. If we're taking a lateral view of quadrant 2 or 3, which is the left side of the patient, the animal's nose is to the left side, as you can see on the right-hand side of the images. My method is to intubate the patient in sternal recumbency. We can then perform a COHAT or comprehensive oral health assessment and treatment in this position. We can then take the radiographs of the maxilla, as I said, with the hard palate parallel to the tabletop, and we'll take a rostral view and 2 to 4 lateral views using the bisecting angle technique. Then we'll roll the patient into dorsal recumbency and have the mandible as parallel to the tabletop as possible. With this, we'll take a rostral view of the incisors and canines, and then 2 lateral views including the bisecting angle technique for these views, and 2 lateral views of the premolars and molars using the parallel technique, aiming the X-ray tube slightly dorsally up about 15 degrees when we're taking the parallel view. Sometimes sternal recumbency is not possible, as you can see when taking a radiograph of this 180 kilogram lion. Sometimes we have to resort to special radiographic techniques such as the Tubeshift technique, and this allows us to push the apices of teeth away from anatomical structures or away from other teeth. If you look at the image on the left-hand side, we have the apex of tooth 104 superimposed over premolar 2, and therefore it's difficult to visualize the apex of that tooth. If we look at the image on the right-hand side, we have tooth 204 superimposed over the nasal cavity with a mesiolateral view. So this view is a tube shift view. It allows us to push the apex over the nasal cavity to clearly visualize the apex of that tooth. And if you can look at the image, there is a radiolucency around the apex of that tooth, the black circle there. There's also widening of the periodontal ligament space in that area, and there's also widening of the pulp canal. If you look at that pulp canal compared to the surrounding premolar teeth. So this would be apical lysis due to pulp necrosis. So what is the tube shift technique? Well, if you look at the image in the middle there, the green arrow shows you the X-ray tube pointing at right angles to the maxillary fourth premolar. Now, if we take that view, often the mesiobuccal and mesiopalatal roots of that tooth are superimposed over each other. And so we may want to see, is there pathology involving one root or the other? So we will use the tube shift, and also the tube shift will be used to move the distal root away from the maxillary first molar as well. Case in point here. Here we have a view of tooth 108, and we have taken a radiograph at right angles to that tooth. And as you can see, the distal root of tooth 108 is superimposed over the maxillary first molar tooth, and we're not really clearly seeing that distal root or distal root apex. If we utilize the tube shift and we move our X-ray tube caudally, the tube shift rule says that anything that is lingual or palatal will move in the same direction as the tube shift, so we'll move caudally or distally, and anything that is buccal will move in the opposite direction or in a rostral or mesial direction, and the acronym for that is SLOB, same lingual opposite buccal. So using this skull as a demonstration, the tube shift here is to the caudal. So that will mean that anything that is on the palatal, such as the mesiopalatal root, will move in the same direction as the tube shift. Normally we'll tube shift by about 30 degrees. Anything that is buccal, therefore the distal root and the MB root, the mesiobuccal root, will move in the opposite direction to the tube shift. So in utilizing the tube shift from that previous radiograph where the distal root was superimposed over the first molar tooth, we can now, if we shoot from have our collimator or X-ray tube caudally moved and we're shooting from caudal to rostral, the distal root being more buccal will move in the mesial or rostral direction, so in the opposite direction to the tube shift. And as you can see now, we can see the yellow circle there shows you that there is pathology around that distal root, and we've also separated the mesiopalatal and mesiobuccal roots at the same time. The tube shift can also be used when taking a view of the maxillary premolar 4 in cats. Often, if we take a normal 45 degrees to the horizontal view of the maxillary fourth premolar in cats, we get superimposition of the large zygoma over the cervical area of that tooth. If we utilize a tube shift and shoot from 30 degrees from the horizontal in the vertical direction, that tube shift will mean that anything that is buccal will move in the opposite direction to the tube shift. So the zygoma, being more buccal, will move dorsally or away in the opposite direction to the tube shift. So now we can see on the radiograph on the right hand side, we can see the zygoma, which is the red arrows, is now moved in a dorsal direction, and we can actually visualize the cervical area of the premolar 4. There is another view that we can do in cats called the near parallel view of the maxillary caudal teeth. And this also makes the zygoma less apparent on the radiograph. And this is where the film, if you look on the left-hand side, the film is placed so that it rests on the opposite side. In this case, we are radiographing tooth 108, and the film is actually leaning against the left-hand side of the hard palate and angled so that it actually hits the quadrant 4 or the right-hand side lower teeth. So with that angulation, now we can actually shoot at parallel to that image or to the sensor or the film, and with that parallel view, now we can see on the right hand side we have a pretty nice view of premolar 4 with some superimposition of the zygoma, but not as much as I would have if we have taken a normal standard 45-degree view. So this is another option that you can use to take a near parallel view of premolar 4. Now, before we can interpret pathology on our dental radiographs, we need to understand what is normal oral anatomy. And to do this, we have to have an understanding of what anatomical structures are there present in the oral cavity. So here we have 4 radiographs looking at the maxillary canine as it ages. If you look at the image on the top left, we have a 6-month-old dog with a developing maxillary canine tooth. And if you look at the image, you can see that the dental walls are quite thin in the root. That's telling us that the tooth is still developing. You can also see that the apex around the end of the root of the tooth is open, and this means that also the tooth is immature and is still developing. So this tooth is still maturing and will still be erupting into the oral cavity at this age. If you look at the image in the middle, top middle there, we have a 1-year-old dog where the canine tooth has fully erupted, the apex of the tooth is closed, and we have primary dentine formed, and that primary dentine means that the pulp canal has closed down somewhat. If we look at 3 years of age, you can see that there's more dentine, and this will be secondary dentine that's formed as the tooth continues to mature. The apex is closed, and we have this effect called the chevron effect, which is an apical lucency, an even apical lucency around the end of the root of the tooth. And we see this in certain teeth, such as the maxillary canine tooth, the incisor teeth, and the mandibular first molar tooth. And this is normal, so don't confuse this with pathology. And the feeling is that it's due to dogs having an apical delta, where there's about 20 to 40 openings into the apex of this tooth, and these neurovascular bundles go through those openings and go into the pulp. So because we've got 20 to 40 neurovascular bundles in this area, the density of the bone in that area is less dense, and so we can see a less dense area associated with this chevron effect. If we look at the image down in the bottom right, we have a 9-year-old dog. You can see that there's a lot of secondary dentine formed. There may even be tertiary dentine or reparative dentine, and now the pulp canal is very narrowed. And with the narrowing of the pulp canal, that is a normal aging of the dog's tooth. We're looking at the rostral maxilla in the dog. This is a skull specimen. If we look at this, we can see on the left upper we have the infraorbital foramen, which is where the neurovascular bundle of the maxillary nerve exits at that foramen. If we look in the middle here, we have the nasal septum or voma. If we look on the lower left, we have the palatine fissures, where neurovascular bundles from the palatine neurovascular bundle enters. On the upper right, we have the conchal crest, and this is where the maxillary turbinates attach, the ventral maxillary turbinates attached to the vertical body or vertical component of the maxilla. Also, we have what's called the floor of the nose, and this is the alveolar process of the maxilla, and it runs along where the vertical maxilla meets the horizontal maxilla, and it can be an indication of where the nasal cavity is, or the floor of the nasal cavity is. So here's a lateral view, a radiographic image of the rostral maxilla. Here we have the palatine fissures, as we mentioned before. There's two of them. We have the voma here, the mid-palatal suture. We have dentine, which is this structure here, which is lateral to the pulp canal. This is the pulp canal here. We have cementum, which is specialized lining of the dentine that allows the periodontal ligament fibers to attach to the tooth, and those periodontal ligament fibers attached to the bone, the alveolar bone on the other side. We have the pulp here, which is the neurovascular component of the tooth, and it is a living component, and it supplies nutrition and also sensory nerve endings to the tooth. Here we have enamel, which is a very thin structure in dogs. It's very thin, usually about 0.5 millimeter in thickness, whereas in people it can be up to 2 millimeters in thickness around certain teeth. Here we have the alveolar bone, which is the supporting bone for the tooth. Now, if the tooth is not present, that supporting bone can dissipate and resorb. This is the alveolar process of the maxilla. You can follow that, and even though this image is two-dimensional, this is the floor of the nose, and so sometimes it can indicate whether a root is very close to the nasal cavity. Here we have the chevron effect, as we mentioned before in a previous slide, and so we can see this radiolucent widening around the periodontal ligament space, which is where neurovascular bundles enter the apical delta. And here we have the periodontal ligament, which is this radiolucent line, which is the supporting structure for the tooth. This is a lateral view of the caudal maxilla. So if we start at the top here, we have the zygoma, which is the zygomatic bone, and sometimes it can be superimposed over the teeth, as we saw before in the cat. This is the alveolar process of the maxilla. You can follow it along here, and that can be considered the floor of the nose. On the left side here, we have the palatal root of tooth 109 here. We have the distal root of tooth 109 here. We have the mesial root of tooth 109 here. We have the distal root of tooth 108 here. You can see there's a normal periodontal ligament space around that tooth. We have trabecular pattern in the bone here, so that's normal. So you can, often around the maxillary fourth premolar, the bone can look less dense, so don't confuse that as pathology. Here we have the cusp tip of tooth 108, and we have what's called a pulp horn, and pulp horns are extensions of the pulp into the cusp tips. And this is why when dogs fracture a tooth, it's not uncommon that that pulp horn is exposed. Here we have the mesial roots. They're superimposed. There's one there and there's one here. Two mesial roots of the tooth 108. So now we go on to the rostral mandible. So here we have the middle mental foramen, which is that radiolucent circle there, and it's normal. So don't confuse that as pathology around the second premolar tooth here, which is here. Here we have the crestal bone, and you can follow that along here. So the crestal bone, if it's resorbed or lost, we would have loss of bone in that area, which we call loss of or clinical attachment loss, which is associated often with periodontal disease. If you can follow, this is the furcation area here, and there's bone in that area, but if we have loss of bone in the furcation area, we'll have a radiolucency there. You can follow the mandibular canal here, so you can follow it here. One branch goes to the middle mental foramen, and then there's another branch that goes forward in the rostral mandible. You can follow it here, that supplies the canines and the incisor teeth, and this is the incisive branch. Here we have the ventral cortex of the mandible, and we need to look at this ventral cortex when we are considering the extraction of the mandibular first molar, especially in periodontally compromised mandibular first molars, where that ventral cortex can get quite thin and there's a risk of causing a iatrogenic jaw fracture in that area. We are now looking at the caudal mandible, and I'll go through the anatomical structures present here. Here we have the cusp tip of tooth 410. This is the right hand side, lower right hand side. You can see a little pulp horn going up here. You can see on tooth 409 there's a pulp horn here coming up here, and another pulp horn coming up here. So again, as I said before, if you get a fracture in this area, it's not uncommon that the pulp horn is exposed. We have a radicular groove in the mesial root of the first mandibular, or the mandibular first molar. So you can see there's a periodontal ligament line running here, and then there's a second line running here, and that's quite normal. Here we have a little bone island. That's a little radiodensity that we sometimes see in the mandible, so that again is considered normal. Here we have cervical burnout. This is where the radiograph goes to very thin tooth structure, so it looks less dense in this area, so don't confuse that as a tooth resorption lesion, especially in cats. As you can see, the enamel of the tooth is quite thin, as I said, around 0.5 of a millimeter. Down here around the premolar 3 here, we have the caudal mental foramen. So again, don't confuse that for pathology. The lamina dura is cortical bone here, which is a radiodense bone where the Sharpie's fibers or the periodontal ligament fibers attach into the alveolar bone. The radicular groove, there's another radicular groove on the mesial root, on the distal root of the mandibular first molar tooth. You can see one radiolucent line there and another one here, so there can be a groove there. This is the dorsal cortical plate of the mandibular canal, and this is the ventral cortical plate of the mandibular canal, and as I said before, we look at the thickness of the ventral cortex to give us an idea whether there's a risk of fracturing the jaw when we're extracting this, especially the mandibular first molar tooth. Other structures here, we have the alveolar bone, which tends to form what's called a ladder-like trabecular pattern. So if you can see, it's like a stepped pattern here, which is quite normal. This is the mesial root of an extracted mandibular first molar. You can see here the groove in the mesial root of that tooth here, and that will cause you to have this double line. If you look on the radiograph, you can see there's one radiolucent line there and a second radiolucent line here, and sometimes we'll see that in the distal root as well, one line here and one line here. So that radicular groove, it's only in the root of the tooth, is quite normal. As you can also see here, that we have also what we call dilaceration, which is root curvature. And this is important when extracting this tooth, because you can actually fracture the root in this area here if you don't realize on radiograph that there is some dilaceration of that root. There was a very recent study, 2020, brought out that looked at the anatomical relationship between the mandibular first molar roots and the mandibular canal using cone beam CT. And this study alarms us as veterinary dentists. You can see on the right-hand side here we have what's classified as apical position 0. So you can see that the end of the tooth root here is well away from the mandibular canal. But sometimes what happens is that in apical position 1, the apex of the tooth is superimposed over the mandibular canal here. So this is the buccal side here. So if you're removing bone to the apex, you may enter the mandibular canal in this area. More worrying is apical positions 2 and 3. So apical position 2 is where the greater than 50% of the height of the canal is involved with the tooth root. So here we have the end of the tooth root here, and we have the mandibular canal. So over 50% of the root seems to be superimposed over the canal. So again, if we're removing bone in this area, we can inadvertently enter the mandibular canal. And apical position 3 here is where the apex extends ventral, so it's below the canal. So even worse here, because if we're removing bone here and we have to get to the apex, say we fracture the root here and we remove bone to the apex, we may actually be into the mandibular canal. So this is quite a worrying situation. Here's some clinical examples of what we've been talking about in the previous slides. So if you look at the top left here, we have a small breed dog. The mesial root is apical position 2, so you can see it here. Okay, so it means that it's possible that the mandibular canal is buccal to some of that root. The distal root is in apical position 1, so some of that root may also be lingual, or the mandibular canal buccal to some of that root. So you can see with those green arrowheads there. And the blue and the yellow dotted lines are the mandibular canals. This is the dorsal part of the canal, and this is a ventral part of the canal. In the lower left, here we have a normal position 0 for the mesial root. So you can see this is the dorsal component of the mandibular canal. So that doesn't seem to be associated with the mesial root doesn't seem to be associated with the dorsal component of the mandibular canal, whereas if you look at the distal root, it will be apical position 1, where some of the root may be associated with the mandibular canal. We've seen this before. I'm a human dentist as well, so this is something that we are aware of when we're looking at extracting the mandibular third molar tooth, this tooth here. You can see the dotted yellow lines to the mandibular canal. So you can see that there is some suggestion that the roots may be superimposed or involved with the mandibular canal in that area. How do you tell? If you look at the drawings up here, if we see the loss of the density of the tooth root, as you can see in this area here, we're seeing loss of density of that root. That usually means the radiograph is going through something that is less dense, such as the mandibular canal, so that will make the root look less dense. The classical example, so on that lower right image, that plain radiograph of that third molar tooth, tooth 4-8, if you look at a cone beam CT image, now you can see that cone. This is one of the roots here, and this is another root here of that same tooth. This is the buccal side here, and you can see the yellow outline here is the mandibular canal, and that would be worrying, is that if we have to remove bone down to this area, we could inadvertently enter the mandibular canal, which is not good for the mandibular nerve. Looking at a cat now, the rostral maxilla in the cat and the premaxillar area, we have the normal turbinate pattern in the nasal cavity here. We have the mid-palatal suture here. We have the palatine fissures, which are slightly different shape than we see in the dog, here and here. We have a fractured crown here, so there's a root exposure here. The pulp is exposed, and so you can see there could be some lysis around the end of the tooth, but we would need to take a mesiolateral view to see that apex more clearly. One thing we do see in the cat is we see these radiolucent areas or less dense areas here, the yellow arrows here, here, here. So that's not pathology, that's considered normal. So the rostral maxilla can be very porous bone, so it can actually look less dense. So we would consider that normal. We're now looking at intraoral radiographs during tooth development. So radiograph A on this side here, on the left side, we have a 14-week-old dog with normal mandibular deciduous dentition. So here we can see the deciduous canine tooth here, and you can see its relationship to the developing permanent canine here. So this is why we have to be very careful if we have to extract this tooth here, because we can damage the crown of the permanent canine tooth. You can also see that mandibular first premolar tooth here has no deciduous precursor, and that applies to all the first premolar teeth in the dog. You can see a deciduous premolar 2 tooth here, and the developing permanent premolar 2 below it. So this is considered quite normal development. In the radiograph on the left, on the right hand side, B, we have a 6-month-old dog with normal maxillary permanent canine dentition, and as you may have seen this radiograph before, this is the normal root development that we're seeing. You can see the root walls are quite thin, the dentine is quite thin, and we have quite a wide pulp canal here with an open apex here, which is quite normal. You can also see on this image that we have a supernumerary premolar tooth, so there's two first premolar teeth here, so one of them will be an extra tooth. You can see the alveolar process of the maxilla, and you can also see the conchal crest here, and that's where the ventral maxillar turbinates attach. That's all considered normal. That's the end of this webinar. Thank you for watching. My name is Dr. Anthony Caiafa. This webinar is the first of a series of 3 webinars. The other 2 webinars will look specifically at dogs and then at cats, and oral pathology and radiographic interpretation of that pathology. I again thank you for viewing this webinar. If you have any concerns or questions associated with this webinar, please email me on toothdoctor@optusnet.com.au. Thanks.